G'day and welcome back to the BroomeDocs podcast. This is the December 2025, the last edition for the year. G'day, Justin. How you going?
Things are great here in Canada, just coming up on Christmas season. I guess that's the same everywhere. Our first snowfall of the year. Get to walk the kid to school in -5, blowy winter, -5 Celsius. I guess you don't get that up there, so you don't really know what it's like. But brisk, refreshing, start every day, just raring to go. It's fantastic.
Excellent. Yes, Ken did send me a picture of his backyard from last week, I think it was, and said, "Oh, you should come and visit." And I think my comment was, "Maybe in the spring, I'll be there." So yeah, it doesn't look fun.
Cool. It's less bad to visit because snow for a week is okay. Snow for 4 months, I don't know.
The novelty wears off, you say. That's what you're telling me. Yeah. Cool. Well, yes, it's the end of the year here in Australia, so we're doing all those crazy Christmas things. I'm completely allergic to Christmas shopping, so I've decided to flee the country for the next month. So that's my plan. So yeah.
It's a good way to avoid it. It sounds like you're going to have a good time and better Christmas gift than any of the trinkets that you're going to find under the tree. So sounds like it's going to be good.
Yeah, looking forward to it. All right, should we jump on into some papers then? Because that's what the people have signed up.
Our Christmas gift to all the amazing listeners out there, yeah, the Christmas edition. It'll be just about as ridiculous as a BMJ Christmas edition, but not on purpose.
We've trolled far and wide to find adequate papers for this Christmas edition. And I think the final paper, if the listeners are out there, you just want to hang around for the end because it gets completely ridiculous at the end. So you need to stick around. All right. I'm going to do the intro for the first paper and then we'll jump on into, I think we got 9 or 10 this month. So I think, so this is high quality discussion of some very low quality papers this month is probably the theme of the anyway. So the first paper is I think this is probably one of our more frequent rants on this podcast is talking about stuff that radiologists make us do, but this one is actually the radiologists seem to be on our side. So this paper is the practice guidance for contrast media hypersensitivity in the Canadian Association of Radiology Journal from August this year. And essentially this is looking at all those sort of things that we think that we should do for patients that have had previous hypersensitivity reactions to contrast media. And, there's lots of things that we've been told that we should do over the years. A lot of it sort of fits into that same category as the whole contrast and associated kidney injury in that we don't really know what helps, but we do it anyway because we think we're doing the right thing. And so for years and years, we've been giving people sort of antihistamines or steroids as a pretreatment for their potential contrast reactions. And Justin, you're here to tell us that that's completely bunk and we can stop doing it. That makes my life easier.
I like it when guidelines are clear and agree with me because we critique. I've critiqued guidelines before that, the quality of the underlying research is a problem, how much it goes in there, but they just say straight out steroids should be discontinued. Stop. Don't do it. It's fantastic. It's one of the many things that I've had a folder on my computer for a while. I think that a lot of evidence-based people have known for a long time. Steroids do nothing except for maybe prevent a little bit of itch, like none of the crazy stuff. And the protocols are like sometimes 24 hours depending on your hospital. So like waiting 24 hours to get a CT scan is not just bad for the department, but like clearly bad for your patient sitting around for that long. So it's been a bit of a sticking point, we'll call it, for a while, and it's really nice just to have a straight up guideline saying do not use it. I don't know. We can quibble a lot about their numbers. I don't think there's a single study out there that says that steroids actually prevent really bad outcomes, but they're optimistic and they say, we think it maybe does, with a number needed to treat of 56,900 to prevent one death.
That basically means it doesn't help.
It's pretty good. But the problem is, and they do a good job of this, most of the time we focus just on one thing, just the benefit without the harms. And so they say if we gave 56,900 doses of steroids to prevent that one death, you'd have a lot of problems from the steroids. And that would include something like 550 hospital-acquired infections and 32 deaths from the infections that you caused. So to prevent one death, you're causing 32 deaths on their math. And you don't have to get that far. I'm pretty sure my 4-year-old can do that math. It ain't good. So do not use steroids. They admit that the evidence is low quality. A lot of it comes from a time when we use different contrast agents. This could change over time, but I think this is what the evidence says, and it's nice to have a strong guideline. There are some other interesting points in here that I think are actually more relevant than the steroid one, because we should just not be using the steroid anyway. We get we just write contrast allergy on every chart. I don't know if you do it better in Australia, but that's sort of just like writing antibiotic allergy. Right? Like, it's like, what the hell are you talking about? So they're telling us you should be specific. And the number one thing you can do to prevent an allergy is just use a different agent. And ideally with CT, there's high osmolality and low osmolality. So you switch to a completely different category. But within low osmolality, there's like 6 different options. You just use a different drug and you're more likely to be in good shape. That's the number one recommendation. They do say you can use antihistamines. I don't know that I care that much because it's only 1 hour beforehand, and whether that's truly evidence-based. Those are sort of the big recommendations. Yeah. Unless, like I've worked in so many hospitals. I worked in, I don't know how many before this current hospital. I've never had anyone tell me that you need to be fasted or NPO before having a CT scan. Like, that is asinine. It never made any sense. But my current hospital thinks that you need to have no food in your stomach for hours before a contrast CT, which I don't know. But apparently it is a myth. Apparently they knew about it. So this guideline also says that's ridiculous. Do not keep people fasted for CT scans. So if you're having trouble with radiology, this is a great guideline. Now, it'll be more helpful in Canada because it's Canadian, but also I'm not 100% sure the radiologist will listen to the guidelines. So that's the next step. I forwarded this along. We'll see where the conversation goes.
Well, a lot of the problems we have is that it's not actually the radiologists that are enforcing these ridiculous treatments. It's often the poor radiographers who are the workhorses that are doing all the, they're the ones putting all the information in and making sure, ticking all the boxes for safety. And I think often they don't get this education because this is something that goes on and on. I just had a look before, and the Australian New Zealand College of Radiologists still have a 2018 version that says we just don't know, which is probably fair because no one really knows. But I don't think they've updated it. But maybe once you guys, your college clicks over, maybe the next version of the Aussie ones will read this one and go, great, we'll change that. I think you mentioned that the harms of steroids is that it's, 1 in a couple of hundred might have a infection, and then we're killing more people than we're saving. But steroids on their own, like the one dose of steroids, sure. But pretty much most people that you give a dose of steroids to at least have some side effects. Like, they might just feel a bit euphoric and not be able to get to sleep for a night. And I'm pretty sure we don't consent people for all that sort of stuff when we talk about the harms and benefits of these things. So I'd say close to 50-50 of people that get a dose of steroids have some sort of mild side effect, which is probably as egregious as a minor itch, I think, in terms of like how it affects their day-to-day function for the next 24 hours. So certainly, it's quite weird, isn't it, that we worry about things that are really rare and probably there's no evidence for, such as contrast-related kidney injury and this hypersensitivity thing, but we just don't give a crap about the really common stuff that we know is going to happen to our patients. Like, we do, but it's just like it never comes up in conversation as a real harm. So I think this is really useful. And it certainly, as you said, appeals to my laziness bias, is that anything that makes my job simpler and I can write less stuff and think about it less, all for it. So very happy.
Yeah, we can probably just cut that segment and put it right into the project we're working on behind the scenes, because that's the exact same, like, that's my paragraph for strep throat, right? Everyone gets focused. Like, there's a bunch of questions in the data about whether it makes you feel better. Maybe it makes you feel better 6 or 12 hours later. Maybe it doesn't. But they just focus only on the benefit. But what about all the diarrhea, the nausea, the vomiting, the abdominal pain? I don't know about you, but like, nausea and vomiting is way worse than a slightly sore throat to me, and that's what we do to our patients. Like, we trade one symptom for the other, but often the symptom we're giving them is worse than what it is. So you can't do a harm benefit analysis if you don't know both benefits and harms. But too much of our research just doesn't look at the harms at all, and that's one of the big problems. So I think that's the key. I don't know that I have a strong. I mean, the steroids one I have a strong opinion about, because there was a clear harm smacking us in the face, where these patients were blocking a bed and sitting around our department for 18 hours or whatever your current steroid protocol was. But when you're looking at these kind of things, you have to think about both harms and benefits. And I do worry that people will be a little bit too strict. So the antihistamine one, I said I don't care that much about. It's an hour, it's an antihistamine. Who cares? But like, if it's a trauma scan and they need to be scanned now, you don't wait an hour for the antihistamine to kick in. That would be freaking stupid. But I guarantee you, someone somewhere will have that written in their protocol and be like, no, they can't have it. They haven't had their antihistamine yet. And so you have to think about harms and benefits of our actions, right?
Yeah, absolutely. And at the end of the day, if you've got someone who's that sick that needs an urgent scan, like that's not the person you want having the severe hypersensitivity reaction. But I think it really behooves us going forward in medicine, and this is something that I do a lot in my practice, is trying to delabel allergies. So take those allergies off people, because when you actually dig into the history, it's like it's a very vague story, or nothing actually happened, or they had a bit, like you say, a minor itch, and then they've been put down as a hypersensitivity. But I think if you're documenting this stuff, you want to actually say what happened to the patient and what did I have to do to fix it. So if someone had a bit of a rash and you gave them an antihistamine and it went away, that's fine. Whereas if someone had full-blown anaphylaxis and they spent 2 days in an adrenaline drip, yeah, that's worthwhile knowing about. So that would be a better way to document these reactions, so that we know what happened and what actually fixed it. Because I reckon 99.9% of the allergies I go looking into, it's probably not a real thing. Yeah, it's pretty rare that you get someone that actually had anaphylaxis.
That actually brings up a different topic that I was going to skip over entirely from this paper. Number one, you're sort of assuming that anybody reads your emergency medicine note. Nobody cares about emergency medicine. They might read a cardiologist note, but I guarantee you they ain't reading your note. So where you store that detail matters a little bit. But so one of the recommendations that I sort of glazed over is the serum tryptase. Or are you using lab tests to diagnose anaphylaxis in your practice right now?
Oh yeah, that's a huge thing.
Yeah, I mean, so it's fascinating, because I would argue fairly strongly, and in my practice has been, anaphylaxis is a clinical diagnosis. And part of my reason is there's 2 patients in our departments that I work in that I am 100% sure don't have anaphylaxis. They have some kind of psychological disorder that presents and they get recurrent stuff. And I've sent it 3 times. It has always been negative, and really well documented note that this probably isn't. And then you send them to an allergist, and they're like, "Yeah, you should treat them with epinephrine anyway, but just assume it's anaphylaxis," despite like recurrent the test. So my opinion so far has been that the allergists don't trust the test based on my thing. So what the hell are we doing it? And I know when it's anaphylaxis as a positive. So it felt to me like one of those ridiculous tests where, like, when you see anaphylaxis, you know it's anaphylaxis. Why the hell are you sending the test? I figured it was going to be like a BNP or something like that, but that's fine. I guess it's there. This is one of those times when maybe you can delabel somebody.
Yeah, I got to say the most time I use tryptase is when you've just induced someone with an anesthetic and you've given them like some kefazolin and some rocuronium and some propofol and Fensol or something, and then they have this reaction. You don't know it's because you put the tube down too far and triggered off bronchospasm. So we tend to use it in that situation because it's just really hard to sort out what's anaphylaxis and what's just me giving a bad anesthetic. So we use it in that situation so we know who to send off for the special testing. I don't use it a lot in the ED because, like you said, it's a clinical diagnosis usually, and that's fair enough. Yeah, cool.
Well, all right. That septic shock patient who's not getting better after norepinephrine, and you're like, could they be allergic as well to like the Piptazo that I gave? I imagine that there are times when you're struggling. Okay, so I won't be completely negative, although it doesn't come back fast enough for me to make a clinical decision, so it still doesn't help me that much. But yeah, I can see the anesthesiologist caring later. Sure.
Yeah. All right, we'll move on to trial number 2, and this one's an interesting one. I had never seen this before. I didn't even hear Weingart talking about it. So, and this is something that actually probably is pertinent to my practice because I work at least a couple of days a week in a stroke hospital that does do thrombectomies. So, it's something I'd never really heard about, and probably will change the way I do things. Maybe not so much in a positive way, but in a negative way. But I'll run through the basic story. So the paper is entitled "Optimal Head of Bed Position."
So, this was a paper.
Sorry. Oh, sorry. It was entitled.
Sorry, I think you just cut out there. That's why I thought you were pausing. Yeah, go. You go. You go.
Sorry about the tech there, people. Optimal head of bed positioning before thrombectomy in large vessel occlusion strokes, a randomized clinical trial. This is from JAMA Neurology, September this year. And this is an interesting trial. So this looked at patients that were coming in with a stroke and they had to have a large vessel occlusion CVA, so usually like M1, M2, somewhere up there. And they were being waitlisted for thrombectomy within their department. So we'll get into the times later, but it seemed like a long wait for a thrombectomy. It was like 4 hours or something. It was quite a long time. And what they did is they looked at these patients while they were waiting to go off and have their interventional radiology stuff done. And they looked at their NIHSS score, so look, how disabled were they? And then they randomized them to either be laying flat in the bed, so at 0 degrees, or have the 30-degree head up, which is where I've traditionally been parking people with brain problems for all of my career is that you tend to put them at 30 degrees head up. And this was an interesting trial. There's a bit going on here. It's an unblinded trial, and the difference between the two groups was so marked that at their first safety stop at about 90 odd patients, they stopped the trial because they thought that the effect was too large. So it was a 34-fold increase in the risk of deterioration, i.e. that your NIHS score dropped by 2 points or more while you were laying there waiting to go and get your thrombectomy, which is a huge difference. Like, we'll go into the numbers, and I'm sure Justin's going to poo-poo them, and I completely agree. But that's basically how they did this trial. So these were patients that had big strokes, and they looked at what happened to them in that period in between arriving and when they actually went off and got a thrombectomy. This is one of those trials where the primary outcome just seems way too good to be true. And we normally don't talk about secondary outcomes, but they're the ones that we really care about, to be honest. So, Justin, are you moving your patient's bed down in this situation?
Yeah, I mean, this is an interesting one. This actually did, whatever screen I used to find papers, for whatever reason, this did pop up on my screen in the early summer or something like that. And because of the trial design, I like small trials that ask interesting questions. And this was an interesting question. And so I downloaded the paper, looked at it, and immediately threw it in the trash. Because I was like, aside from maybe people on our podcast, nobody wants to hear about this. This is not a paper that matters at all. And then instantly, the next week, it was on Weingart's podcast. And he specifically called me out. He's like, "This is practice changing. Justin Morgenstern, if you disagree, come at me," or something along those lines. And I was, oh, okay. Maybe, all right, I'll re-download it and I'll have a look again, because apparently people are interested in this paper. So I like the design. I like the idea. I guess gravity could have an impact. Although I've never really believed. I know some people, you see somebody go into shock and they're immediately doing Trendelenburg or reverse Trendelenburg, whatever it is. I've never really believed that could have an important physiologic difference. I mean, I'm not trying to stand a syncope patient up. They can lie down, but it never made a lot of sense to me. So part of my issue with the paper is just pretest probability. What are the chances that this really has dramatic outcomes? And I think that has to be factored in. And then, I saw if it was just stroke outcomes, I might have spent a little bit more time with the paper, but I saw the all-cause mortality, 22% versus 4%.
Yeah.
I don't think in my career have seen anything that has an 18% absolute decrease in mortality. Yeah. That is, we're saving 1 in 5 patients by doing this. 3 hours of this, and it literally is saving 20% of people's lives. That fact. Maybe I was a little bit too hasty in throwing it out, but it just is unbelievable to me, and not unbelievable in the good way, but literally unbelievable.
Yeah.
I think it clearly warrants further follow-up. This study, whether I might quibble with Scott, in my write-up, I said maybe Scott's right. Maybe this is practice changing. The more I think about it, this at most is a pilot study, because the primary outcome, what they looked at, was neurologic outcomes up until the moment where they actually perform the EVT. So neurologic outcomes before the procedure that we know has an impact on your long-term outcomes. Who cares? That's just not a relevant time frame. Maybe that is associated, although I looked around briefly. I haven't seen any good studies that say that you're that 1 hour, 2 or 3 hour window before EVT makes any difference to long-term outcomes. Maybe it does, but clearly that is just a pilot saying, okay, there's something here. Let's actually look at long-term neurologic outcomes. And that's what you got to do. And so when you combine the fact that they're looking at very, very short-term neurologic outcomes in an open label trial where you can very clearly tell which group the patient's in, and then come up with some just completely implausible numbers. That's why my initial instinct was this isn't practice changing. Now, the words practice changing are really interesting, and I've written more about that, I think, somewhere else. If you're working in a stroke center, do you really think there's a big harm in lying somebody flat for a couple hours? Probably not. I think we need to be careful, because we do know actually stroke patients need to have the head of the bed up for aspiration reasons and things like that. So it would be problematic to extrapolate this to all stroke patients and to leave them like that for 2 or 3 days. But if we limit that, then yes, I think this could be practice changing, because even though I would bet more than 90% this turns out to be not true. I don't think that this is going to be true. It's still maybe enough to change practice, because who cares what the head of the position is. Now, the flip side of that is generalizability. This is only, they excluded anybody who was being transferred, which means if you're not working in a stroke center that provides EVT, the results don't matter to you, because again, like how you transport it, I don't know. And so it doesn't apply to anywhere that I've ever worked. I don't know that I'm fighting with EMS or a helicopter to figure out like what position they should be transferred in. We're not at that level. So I think it's only practice changing if you work in one of these centers, and who cares what you do for 2 hours, then yeah, sure, do it. As long as you know, almost certainly the next trial is going to be negative. There's just no way that it's not going to be negative, but we'll see.
I think the you could sort of see as their secondary outcomes went on and on, sort of longer time periods, that the sort of the amazing statistics started evaporating pretty quickly. So the 24-hour NAHS score was sort of, I think it was an improved NAHS score was 87% in the head flat group versus 60% in the head up group, which is starting to evaporate. And I'm sure if you took that out to 3 months, I can't remember what the actual numbers were, but it wouldn't be as impressive. I think interesting at baseline, there was about a quarter of the patients were actually being nursed flat anyway. So this is not something that's, standard practice in either way. So I don't think you can, there's certainly equipoise. So I think you could definitely do the trial again and say, we'll do it properly with, 10,000 patients and do it and structure it so in such a way to decrease the biases. It's pretty hard to blind it, obviously, because all the patients.
And the blinding is not going to be a thing. But honestly, what you want to do, and I can understand for a pilot trial, which is why I would quibble over this, like in your centers is fine. But what you really want to do is most of these patients are transferred. So what you really want to do is look at the patients that have to have the 3 or 4 hours. They have, like, they're getting in an ambulance and they have to go. To me, you got to enroll those people and have the whole transport. Now, you got to be careful not to, like, I assume Broome, you can't get people to this kind of therapy in time, but air transport's not going to work because you got to be a little bit more specific. With ground transport has the ability to go up or down. So I think you need to include everybody and not just the people showing up to your center, because that's going to matter for long-term impacts. And yeah, it'd be interesting. It's worth a follow-up study. And in the meantime, I don't really have strong opinions, but yeah, if somebody asks me to put the head of the bed down, I'll put the head of the bed down. In fact, I'll probably just do it, because why not? Even though this will almost never come up to me in the places that I work.
Yes, I guess one of the clues to that could have been differences. If you look at the baseline between the two groups, the stat that really jumped out at me was that the patients that had the head of the bed down were almost twice as long to get to their EVT. So they were like, I think it was like, and that doesn't make any plausible sense whatsoever. Like,
it's because you can't see them. The patients who are up, they're like waving at you. Can you get me in there? Can you get me in there? The ones who are lying down, you just overlook them. That's the problem.
So for the statistics nerds out there, that is pretty much that is the fingerprint of bias right there. Is that we could argue that putting the head of the bed up actually makes you get through the scanner quicker. So yeah. It's a weird correlation, but it just happened to be in the paper. So, all right, interesting. It'll be fun talking to our neuroradiology people next. I'm at work tomorrow, so I'll ask them what position they want the head of the bed in. They'll probably look at me slightly weird and wander off, because they all have to lay flat to go through the CT anyway, so it doesn't matter. Cool. Next paper. Next paper really sucks.
Yeah, the buddy Ruben Strayer. Is an interesting little study. It's nice to see some of the FOAMed folks publishing RCTs in big journals and in real journals. I like this little study. It's in the Journal of Emergency Medicine. It's entitled "The Impact of Suctioning on Oxygenation During Rapid Sequence Intubation in the Emergency Department: A Multicenter Pilot RCT." Just published this year, and I thought this was a neat little study. I don't know that it must be one of those things that's just sort of like in little pockets, because it makes sense to me that sticking a suction in the mouth might suck some oxygen out of the mouth, but it's not really been a thing that people talk about in my circles. So it hasn't been a big thing, but the idea is we can back all the way up to our buddy Jim Ducanto, came up with some really brilliant techniques, but the idea is his salad technique. When you have a really soiled airway, what you want to do is get your suction and go in first, leading your video scope so that you suck everything out. And then the most important thing, what we didn't used to do, we used to suck and come out, is you just stick the suction all the way into the esophagus, tuck it to the left side of the mouth, and just leave it there so you have ongoing suction during your procedure, hopefully preventing further aspiration. So Great technique. I used it for sure in soiled airways myself. But the concern that this paper was looking at is if you're leaving that suction in the airway, especially in an era where we talk about apneic oxygenation, where we think that the oxygen we're providing during the procedure is going to continue to make it all the way down to the lungs. Are you sucking the oxygen out of their lungs? Are you going to make things worse? And actually a pretty easy thing to answer in a little RCT, depending on how you're doing it. And so that's what Ruben Strayer and colleagues went after. Pilot RCT from three RCTs from 3 hospitals. I think the only quibble is that apparently in some places, and I think in the hospitals that went after this, they're doing the salad technique routinely. For like all patients, not just patients who are having suction, which is a little bit weird to me. Like it's not just the people with soiled airways. So in fact, to get into this trial, you were excluded if you had known or predicted heavily soiled airways. So they were assuming that you needed salad if you had a soiled airway. So they're just doing it in the standard patient. And I don't know if they're doing that just for the trial purposes, or the way I read it, I think that they think that you should just do this routinely to maybe prevent aspiration, which I hadn't seen. So it's not in the high risk patients. Small trial, 76 patients. And basically the quick summary is that the oxygen saturations were just unchanged in both groups. I think the only quibble, aside from what patients you would use this in, that I had, is that these don't seem like difficult patients. Unless I'm blind, I didn't see a first pass success rate mentioned anywhere in the paper. But they mentioned time from procedure till they confirmed endotracheal tube, and it's like less than 80 seconds in all of the patients. And so patients who started at 100% and take less or a minute to intubate to confirmation are not exactly the patients where apneic oxygenation would make any difference, where I would expect them to have any problems. So just because they didn't find a difference here doesn't mean that in a patient where you're starting with a stat of 93% and they're more borderline, or the patient where, for example, you might have wanted to use BiPAP throughout the entire apneic period, where you might actually find a difference. But in the routine, average, easy intubation, they found that suction did not suck all your patient's oxygen out.
Yes. Yeah, I think that's the real problem with this paper, is that they found no difference, and you could walk away from this saying, oh, it doesn't matter, you can just do whatever you like. But the one where you really want to know is the one where they're starting out with borderline sats, they're gurgling on blood, and you're having your 15th attempt at getting the tube in, and it's been a real struggle to get it in, because that's the group where it may make a difference, because they need every molecule of oxygen that they can get. So they're not going to answer this question ever. Like, no one's going to do a trial with 1,000 heavily soiled airways randomizing these things. So I think it's a great paper, but it can't really answer the question that we all really want to know, is, does it matter in that critical borderline case, as you mentioned? So I think I did put it to a bunch of anaesthetists, and it was a real head scratcher. I said, what do you think it will do? And about half of them said, oh, it will make it worse, and half of them said it wouldn't make a difference. So it was quite interesting. So I think
it's a legitimate concern, but and I love it. So I absolutely love the RCT, but it's hard to get a definitive answer. And the person I meant to, I kept meaning to email and I completely forgot, is actually DeCanto. I actually think his critique with this might be different. My understanding of salad is, you suction in the airway to begin with, but you're really supposed to tuck the tip of the suction like all the way down into the esophagus, so it's out of your way. And if you're suctioning in the esophagus, then you're no longer suctioning oxygen anyway. So I think proper salad technique might not actually impact the air at all. But maybe I'm misunderstanding that. It's been a while since I've watched one of his videos sort of going through the procedure. But that may be the thing that mitigates all of this, is that you're supposed to be, I think, pretty aggressive with that proper decanto suction and get it all the way down and out of the way, plug up the esophagus.
All right. Well, Jim, if you're listening to this, hit us on the email. Leave an angry comment on Justin's website. That'll be perfect.
When idiots talk about your procedures, the procedures named after you, and get it all wrong, it's got to be frustrating. But luckily, nobody listens to us on the podcast, so it's okay.
I did notice one small technical point in this paper. It just irked me a little bit. Is that this was done in Brooklyn, I can't remember where else, and RPA, which is a hospital over in Sydney, and RPA stands for the Royal Prince Alfred Hospital. And they wrote that in the abstract, but in the main part, they wrote the Royal Prince Albert Hospital. And if you know what a Prince Albert is, that's a whole different thing. So
Ruben Strayer doesn't make mistakes. He did that on purpose. I guarantee you.
So No, but my point is, if he really wanted to make this very funny, he would have called it the Royal Prince Andrew Hospital. That would have been even more hilarious. So he's no longer a prince, of course. So anyway, so if you want to know what a Prince Albert is, you just go and look it up on Google. Maybe not at work, though.
Yeah. Be very, very careful.
Be very careful. All right. Next paper. Let's move on before one of us gets the sack. So this next trial is, this is complicated. So this is going to be, this is the Andromeda Shock 2 trial, which is a really big and well done randomized trial. And the actual title is Personalized Hemodynamic Resuscitation Targeting Capillary Refill Time in Early Septic Shock. And this was in JAMA just October 2025. And this has got all the ICU people very excited because it's like a whole new way of doing personalized resuscitation. And if you read through the protocol, I don't think we really need to go through it all here, but there's 2 different tiers and there's all different steps within each of the tiers. But to be honest, most of it's stuff that most of us are already doing, not maybe in the emergency department, but in that next sort of few hours of resuscitation. Unfortunately, those patients are still largely in the emergency department where they should be in ICU, but that's where they are. So to get into this trial, you needed to be pretty crook. You need to have septic shock and a cap refill of greater than 3 seconds. And then there was a whole heap of things that they did targeting really mainly clinical things, which is quite nice because you didn't need to have a fancy Swan-Ganz catheter or some ridiculously expensive machine. So it was sort of stuff that you could get off the BP or an art line. And the other thing I really liked about their protocol, it was really pragmatic. It was like, well, this person might need a bit of cardiotropic support, so we'll just put them on dobutamine for a little bit and see if they get better, which is how we actually do ICU care. Is we try something, and if it doesn't work, we stop doing it, and then we try something else. And so these protocols are actually, I don't think there's anything new in these protocols. It's basically how we do it, but they've just sort of protocolized it for the sake of a trial. And the bottom line was they seemed to think that targeting cap refill in this sort of algorithm seemed to make a difference. Depends on what you call your happy endpoint, because the mortality in the 2 groups was 26.5 in one group and 26.6 in the other. So I don't know about you, Justin, but that sounds like a negative trial to me. But tell me, why is it a negative trial rather than what it's been written up as a positive?
Yeah, I mean, this one, it actually may require people. Almost every paper requires people smarter than us, but. I mean, everybody in evidence-based medicine for a very long time has said the composite outcomes are a big problem, right? They combine a bunch of things together, and mostly they just confuse outcomes, but often they allow less important outcomes to drive the outcome, but it makes it seem like really important outcomes are changing. And we just know they're bad. And I think even the authors of this trial know that they're bad. But there's an interview on MCRIT that people can listen to. And their excuse is sort of, but the cardiologists have been doing it for a long time and nobody gets angry at them. And I'm not sure that's a good excuse. I mean, it's true. The cardiologists get to publish a lot of big papers and a lot of big trials. But behind the scenes, everyone gets really frustrated by their stupid MACE, major adverse cardiac event. They use all these composites, but I guess it's true that from a promotion standpoint, they get to publish big trials and people go. So that's sort of the excuse. It's a bit of a problem. What makes it more complicated than your average composite is they use this hierarchical composite. So they say up front, we know that mortality is more important than vital support, which is their second thing. Vital support is a composite itself. So we have a composite within a composite, which makes it even more confusing, but a composite of things that you would think of vital support. So mechanical ventilation, vasopressors, renal replacement therapy, that kind of stuff.
Yep.
And then they also combine that with hospital-like stains. They just all mush that together. But at least because it's a hierarchy, they do this thing where they basically match every patient against every other patient in the trial in some giant tournament, and they compare mortality first. And it's only if you tie on mortality that you go down to the next level and you compare the next level. And it's only if you tie on that level that you go down to the next level. And so it is marginally better than a standard composite. But in my mind, I've struggled back and forth. We talked about this before. There was a big peerless trial for PE that we talked about the same thing. And at the time I was like, this makes a little bit of sense. And on its face, it makes sense. But the longer I sit with it, it's just a composite outcome. Because the problem with the composite outcome is you read the abstract and it says there's a difference, but the average clinician has no bloody clue what the difference is. And so the only way to get information out of a composite outcome is to read the secondary outcomes, which means that you're making all your clinical decisions off of secondary outcomes, which is not what we're supposed to do. And so it just becomes this mess where everything becomes a secondary outcome. So I think it doesn't make any sense. And I think it's a little bit, this maybe go a little bit long, and it's a little bit too nerdy. But I think it's just a misunderstanding of why we dislike secondary outcomes. Like, there's no reason to combine these together. If you really think there's a hierarchy, say mortality is our primary outcome, we will have a single, not our usual 20 secondary outcomes. We'll have a single secondary outcome, vital support, and we'll have a single tertiary outcome. And we can have a single quaternary outcome, because the reason we don't like secondary outcomes is just twofold. Number one is because we often throw 100 at the wall and just see which ones stick. We only talk about the ones that stick. But if you register ahead of time one secondary outcome, that problem goes away. And then the other thing is that we statistically, for every extra outcome you add, you're supposed to adjust your stats, and nobody ever does that. But if you did this, you could use a p-value of 0.05 for mortality, and then for your secondary outcome, this vital support, you could use a slightly stricter p-value. And then the third outcome, you could use a slightly stricter outcome, and you could adequately adjust. So there's no reason to cram them all together. Just tell us ahead of time we have a primary, a single, not multiple secondary outcomes, a single secondary outcome, a single tertiary outcome, and just look at it that way, and it would be clean, and clinicians could actually understand it. Anyway, that's a big aside. It just means that it's really, really hard to assess this paper, and even more so because the thing that's positive is a composite within their composite. Vital support is not a thing. It's not a thing that exists in real life. And they don't even tell us the components in the manuscript. So I had to dig through the supplementary material. And I think the only thing that changed, it's hard to tell, but I think the only thing that changed in this trial was about 1 day of renal replacement therapy, which is pretty questionable from a patient-oriented outcome. Like, you're hooked up to a machine, yes, nobody wants it if you're outside of this trial, but if there's no difference in mortality, there's no difference in long-term dialysis, which they don't talk about at all, there's no difference in long-term functional outcomes, do you really care if you're hooked up to a machine for one extra day in the context of, like, I was about to die, I was critically ill? I don't know. But even more important than that, let's ignore which one's patient-oriented or not. This is an unblinded trial. And these are, when you're talking about vital support isn't a patient outcome. That's I knew that was going to happen. I will. That's okay. It only affects the video and now my rambling. But vital support is a clinician-oriented outcome. It's not a patient-oriented outcome. The clinicians are making the decisions, and this is unblinded. They know what group you're assigned to. So I decide how long you're on norepinephrine. I decide how long you're on mechanical ventilation. And in a trial like this, where you're forced to be at the bedside every hour for the first 6 hours, you're probably going to make different decisions as you go along. So a subjective clinician-driven outcome as a secondary outcome changing in an unblinded trial, I am pretty unconvinced that this is a real outcome when there's absolutely no change in mortality. So that's my primary critique with the trial from the negative standpoint. There's a ton that you could be talking about here, but I feel like I've been talking for about an hour and a half now, which is why my camera shut off. Sammy, shut up. So I'll let you get some word in.
At the end of the day, what they're actually the intervention here is actually really cheap, and it's actually something that is probably just good medicine. So there's no actual, like, okay, you're forcing people to do a protocol of stuff that's actually commonsensical and pretty good medicine, a lot of it. So I'm not too bothered about the outcome of this trial because it's not like they're trying to sell me on, activated protein C for $40,000 an ampule or something. So I'm not too bothered. And I think my takeaway from this is that, and that's probably one of the problems, is that when you do a trial of just what is good bedside medicine, essentially a lot of what they're doing here, chuck an echo in here and there, is that the Hawthorne effect's going to be huge as well, because you've suddenly got a heap of investigators that have a vested interest in, like you say, sitting by the bedside and looking at, is the diastolic blood pressure 38 or is it 42, and we'll do something if it isn't. And so these patients are probably going to do better. So the bias probably would be towards some sort of positive trial here. And the fact that the numbers were so close, like, it's difficult to calculate a fragility index, but I'm sure it's close to 1. Like, if you move one patient either way, it would probably change the outcome to be negative. Yeah. So I think I'm not too bothered, but I think it was an interesting trial. And if you read through the protocol, there's probably some good learning there for the readers, just to go through and say, well, which things did these investigators, who are very smart people, think were useful to go chasing in terms of numbers, and cap refill and diastolic blood pressure. pretty damn easy to do at the end of the bed. As long as you don't smash the glass slide that they use for measuring into the patient's chest, that would be bad. Why they didn't use plastic, I'd never get away with that in my health service, so it's all good.
Yeah, I'm not sure we need to use a slide. I just squeeze the patient's finger. But I will push back on one point, but I think at the end of the day, we mostly agree. Cost is an interesting thing. So for the ICU doctor who's looking after a very limited number of patients, and like I think they're already doing all this stuff, it's pretty low cost. Yep. But I guarantee you this will be talked about as if it's standard of care. And who does it fall on? It falls on the emergency doctor. And 6 hours of time at the bedside is a pretty huge opportunity cost when I have 50 patients waiting in my waiting room. So opportunity cost is real here. And so I do not think people should be following this specific protocol. But and actually there is a different you talk about the Hawthorne effect, but I actually wonder whether that might push you towards a negative trial, because they did a lot of education for all of these centers. And I think they're going to be pretty gung-ho. So I bet you their usual care looks very much like the protocol, because they're really gung-ho into all these things. So it actually might have is contamination bias, where both groups look very, very similar. It could look the other way.
Yeah.
At the end of the day, it comes back to those words, practice changing. Because what practice changing is really highly dependent on what your current practice looks like. And like, we're talking about sick patients who are still hypotensive despite being on norepinephrine. Like, everyone agrees that they need resuscitation. They need a clinician at the bedside.
Yep.
And you can't do resuscitation blindly. Like, you have to have some target. Your target might be a map. It might be I don't know what it is. But since Andromeda Shock, the initial one, was one of my favorite papers of the last decade. Brilliant trial by the same researchers, fantastic. And since then, I've been using cap refill rather than trending lactates for a very long time. So I'm already using cap refill as a target. I'm already resuscitating these patients, and I'm already doing a number of these things. Like, look, if you're not getting better from my norepinephrine, I'm probably putting an echo probe on your chest, even though I'm not as big an echo nerd as you are, because like, at some point that needs to happen. So a lot of these things are already part of normal care. So it's hard to know what really is practice changing here. I guess the only thing to back up on is when you put this whole bundle together, it's a little bit problematic, because I think we talked about it just a month ago. Targeting higher MAP values is just shown to be harmful in the I think it's called the Optus trial or whatever. And so when you have this big bundle, it's possible some things are actually harmful and some things are beneficial, and it's so hard to know. So I 100% agree that we need to be resuscitating these patients aggressively. I think you need to have a target of your resuscitation. I think cap refill makes some sense. And so my care is not going to look dramatically different than these patients, but I'm not following this protocol. No way. It's too intensive for an emergency department. And I don't think it makes necessary sense to follow it in the exact order that they're doing. But I mean, if ICU wants to grab these patients and take them away from me as soon as possible and get them upstairs, I'm all for them taking them out of my emergency department. Sure. The other thing.
I will say, like we talked a bit about laziness bias earlier on with the contrast reaction. This is sort of the opposite of that, in that I think most ED docs, because we're trying to look after 30 patients at once, and it's so much easier just to glance over at the screen and see the map coming up on the big red number on the monitor. And the nurses call me all the time and say, "Oh, the map's drifted down to 60. You want to do something?" I've never had a nurse come to me and say, "Oh, the cap refill's 3.5 or 4 seconds." Like, and maybe that we think that is a useful parameter to be chasing, and it's very cheap. Maybe that's something that this trial will do, is just re-highlight that is a very useful parameter. And it's not one thing that you're looking at. You're looking at 7 or 8 different things at the same time and putting it all together. And that's what your brain's for, is basically synthesizing all that information. So I think, I don't know, maybe I shouldn't be an ICU nurse, but that's what we need to do.
Actually, it's almost like we should skip around, but we'll put a pin in it and just remind people when we come back to the Canadian emergency medicine paper later on, is emergency medicine savable or dead or whatever? Because it's exactly that. You have to remember that this is our core mission. And if there's somebody if you're going to work as an emergency doctor, you probably should want to spend 2 or 3 hours standing at the bedside of this critically ill patient thinking you can make a difference. But yes, there's a lot of things going on in the department, and it's just not feasible a lot of the time. And that maybe is symptomatic of a bigger issue, because I think most of us would like to become ICU doctors for short periods of time and do it. It's just whether that's actually feasible. But if you're ignoring this patient, if you're not going back and checking, it doesn't have to be every 30 minutes like in this trial. It doesn't have to be this exact protocol, but it is pretty tempting. You get pulled way to the other side of the department. You got to do a reduction over here. You got to deal with the psych patient. There's a code white, whatever it is. If it takes you an hour and a half, 2 hours hours to get back to the patient, I think we have a problem. And maybe that's the biggest reminder of this trial is these patients need hands-on from the expert, and that expert is you.
Yeah. We will come back to that.
Maybe not
shortly.
you specifically, Casey. I'm talking about general you.
General you. The listeners are the experts. That's right.
Yeah.
Do you want to introduce the next paper, and I'll tell you what I think about it, because I may be biased.
Yeah, no, this one is for you. I mean, it's another one that depends on your listener. It's really just an ICU study, so it may be not that important to the emergency department. This is like looking at art lines. So the trial name is Deferring Arterial Catheterization in Critically Ill Patients in Shock from the New England Journal of Medicine. First author is Mueller, and just a big RCT comparing 1,000 patients, comparing should we have an art line in or not, to the point where if you had an art line placed by the emergency department, they actually took it out. That's how aggressive they were to randomize that, which I've never actually seen. That's pretty interesting. And the headline, we can dig into some details, but the headline is no difference between the two groups. So I'm interested to hear your thoughts.
Well, it's one of your favorite types of trials, Justin. It's a non-inferiority trial. So for those of you listening, the first-time listener usually gets Justin's blood pressure up about 5 or 6 points. So these were patients that were sick. They had a low MAP or a low systolic blood pressure and signs of decreased perfusion. So maybe they had a prolonged cap refill or dodgy lactate or something like that. I don't know what they were counting, but and they were randomized, as you said, to either have just ongoing monitoring with frequent non-invasive blood pressure cuff monitoring, or they got an art line put in, and then they followed them up and saw what sort of happened. As you said, there was no difference in the two groups, though there was differences, because the differences were the predictable differences in the people that had outlines. You get more pain up front, but you don't get 7 or 8 blood draws done over the course of your day. So you had less pain and less total phlebotomy done, I guess. And the people that did have an outline, they had more complications related to their outline, so bleeding or hematomas at the site. So completely reasonable. I guess I do question the ethics of removing an outline that's already in for the sake of the trial. I would have been happy to
jumped out at me. It's so bizarre. Like it is really, really, I mean, it's a very strict trial design, but yeah, I've never seen somebody being like, you already did a procedure. Let's just cancel that out. You can imagine like extubating somebody just for the purpose of a trial, comparing it.
We're going to put you on non-invasive now. Yeah. Yeah.
Really, really interesting. I will. Well, while you're on the harms there, I will. I've never considered this. I think only because I'm in the emerge and we don't do things. But actually, the biggest harm they had was people complained for, they call it persistent. I don't know how long, but pain where the blood pressure cuff is. I guess that's I guess if it's going off every 5 minutes for like a week, maybe that makes sense. But it's not part of my practice, and I wouldn't have considered. I mean, yeah, it's a little uncomfortable, one squeeze, but I guess if you're doing it over and over again, persistent pain from the non-invasive is not a thing that is unheard of in ICU. Never even crossed my mind.
And sleep, like if you work in a HDU, like people describe blood pressure cuffs as waking them up every 10 minutes when they're sick. That's torturous, you know. Like it's imagine you're trying to get to sleep on an airplane and someone keeps squeezing your arm every 5 minutes. Yeah, it's not good. So,
honestly, I was on the fence, but that one point right there might push me back into camp art line, honestly. But anyway, let's see.
And so I tell you what my practice is that, and see what you think, but the two situations where I really want to have an outline is one is that really rapidly shifting patient where, you know, things are very unstable and their blood pressure's all over the shop. And you know the sort of patient I'm talking about, because every time you cycle the blood pressure, it gives you a wildly different number, and you don't know what the hell you're doing. You're titrating things and you don't know if the number's really true or not. And particularly I find that with the AF patients, you often get that as well, where this blood pressure is just completely ridiculous, and you can't, and often you end up doing things that are potentially harmful to that patient, like giving them more blood or more presses when they didn't really need it. You just were using a dud measurement. So I think that group of people I really want to have an outline in, so that's a reasonable time to use it. But that normally lasts for half an hour or so, like it's not very long that you need it. And the other group I think is the ones, and they mentioned that in this paper, where you're doing frequent blood sampling where you need to get arterial samples for measuring CO2s and so things like, I guess the unstable DKA patient, where they could be like that for 12 or 24 hours, where you're needing to sample their blood frequently. That gets a bit old if you have to stick the patient every time. Our nurses more and more are doing this for venous lines now, so I don't know if that's a practice in Canada, but they're often sampling things, and you can get most things that you want off of a venous catheter, so it's not too bad. But those are the two areas where I think it's sort of humanitarian, really, to use an outline, if that makes sense. And I'll often have that conversation with the patient who's not too unwell, but you can predict their future that they're going to get 100 blood tests in the next 3 days. You say, well, we can do this one stick now and it'll last 3 days, or we can do this repeatedly. So I think that there are some small differences, but in terms of clinical outcomes, I'd be very surprised if the humble outline made any difference to actual clinical outcomes. Like expecting a mortality difference seems very, very optimistic, because that's just not how monitoring works, unfortunately. Monitors don't fix people.
Yeah, I think that the 2 points. My minor quibble was the difference in arterial blood draws. My understanding, I think the only thing that's different, arterial versus venous blood draws, is if you're really looking for oxygenation. And most of the time we have a SAT probe. Most of the time oxygenation is not our issue. There's very few conditions where we need to monitor oxygenation that importantly. Everything else is perfectly fine off of a venous draw. And so if I was doing this trial, I think you need to have that pretty regimented. Here are the appropriate reasons to do an arterial blood draw, because otherwise the outcome is just, here's how traditionally we've done it. We're used to having arterial blood draws. It's going to be different if you take somebody's art line away. But you still need to draw blood out of somebody, and poking somebody it's not like the venous draws are free, although again, it depends on whether you're allowed to draw through a central line and blah, blah, blah. Having a line in place to get blood is a reasonable thing. To me, the biggest thing, it's an ICU study. I don't work in the ICU. And to me, I just don't see this being generalizable to the emergency department, because despite being critical care and ICU, their patients, although sick, are actually way more stable than our patients. The first couple hours is when things are chaotic as all hell and you don't know. So I don't think that this applies to the emergency department, or maybe like a really complex surgery when things are just chaotic and going off the mats. And if I was going to guess that an art line could ever have a mortality benefit, it's that. It's the patient who's borderline PEA and we keep doing stupid things because we think they don't have a pulse when they really do, or we're just not, you're trusting in a non-invasive cuff. And it's just, there's no way when they're just shocky and AFib, like you say, that you're getting anywhere close to accurate numbers. Monitoring doesn't matter in the long run, but when you have absolutely no data on a critically ill patient for the first hour or two, I could see potentially a mortality benefit. I'm not saying that it's going to be. I think there's other clinical outcomes that you can use. You can use your ultrasound, blah, blah, blah. But I would not apply these numbers to the emergency department. But unfortunately, it's flipped. ICU almost always has an art line. Only a handful of emergency departments routinely start art lines. I've been trying at both of the departments that I do, and it's just they're not well set up to use them in the patients that I really want to use them in. And then when you don't have the practice and it's not snowballing and you're not using them all the time, it just doesn't happen. So my big concern would be extrapolating this to that critically ill patient. When you have them going in and out, people are doing chest compressions and stopping, and it's like PEA, and you just don't know. An art line is really, in my mind, essential to that patient. Whereas on day 2 in your ICU, who cares? It's a comfort issue. And I think there's arguments on both sides. And I think we should just need to be a little bit more regimented about how we treat these patients. If you're using a blood pressure cuff, how unstable has the patient been? If they've had pretty stable blood pressures for the last 24 hours, you can probably scale back to hourly, 2 hourly, or rather than we should think about patient experience a little bit more, and the art line's only part of that.
Yeah, and I think you hit on a good point there, is that when those patients, and I think massive transfusion would be a good sort of population to study this in, when the patients are all over the shop and they're sort of transiently responding to volume with blood or whatever. And in those patients, I want a femoral line in. I don't want to go with a radial line, because the radial line's just giving you bad numbers as well, because they're not perfusing their hands. And so, so the patients we really care about, you're probably better off just chucking a femoral line in and getting a proper central arterial pressure so you know what you're titrating to. So, I wouldn't be too fussed if people took away radial outlines for those patients, because I'm going to put a femoral line in those if they're that unsteady anyway.
I think it might be the key to transitioning as well. Initially, everybody's used to the radial line, but it's like with ultrasound, this shouldn't be that hard, but it is a little bit more finicky. In a crashing patient where you're going back and forth, you don't want to be near the chest where people are doing things. I think if we just made it the standard in emergency medicine, just go for the groin. I know that in ECMO centers, they're really, you have to be a little bit picky about where exactly you put it in, and there's some training because they're going to upsize it really big. I don't have to worry about that. But man, is it easy to hit the big vessels in the groin. And if we're just talking about temporary, we don't care about being perfectly sterile and blah, blah, blah. I'm with you. If I have the choice, you have to stock the right equipment. But if I had the choice, I just throw in some lines in the groin and then figure it out later.
Cool. Well, that's a lovely segue to our next paper, which is, of course, about the sterility of putting lines into people. So should we have a chat? This is a paper entitled Post-Procedure Perforation Rates in Ultrasound Transducer Covers Used for Ultrasound-Guided Percutaneous Procedures in the Emergency Department, a comparison between polyurethane and polyethylene covers in the Australasian Journal of Ultrasound in Medicine, September 2025. And of course, the lead author is our good buddy, James Rippey. And the other authors are a couple of consultants who I work with at Sir Charles Gardner. So great to have a local paper.
Let me just point out to everybody in the audience, this is how you know for sure that Casey Parker is not a true researcher, because this is his department in ultrasound. He doesn't even get his name on the paper. So you should probably not listen to anything that he has to say, because if you can't even get your name on paper run in your department by your best buddy, we got some problems.
I think,
but not Casey Parker, I'll point out, not on the author list.
I did contribute a number of samples to this trial. I remember this trial we were doing.
All the tears are your patients.
Probably.
Your bare hands just tearing at the covers.
I think the real reason that my name's not on this paper is that, well, Rippey's the god of all things ultrasound, so he's of course the lead author, and all the other guys were at that stage in their career where they were sort of senior registrars trying to get a publication to get their name so they could put it up for their interview. And I think we can all agree that my career has been flatlining for about 20 years now, Justin. So I didn't need my name on any papers and would be happy never to write another one. So,
if anything, I've been dragging you down. Yeah, you definitely peaked before you and I met, and since then you've had an anchor. You definitely had an anchor.
I have never had a job interview in my life. I'm just going to point that out. Just wandered blindly through medicine. So there you go. So basically this is a basic science paper, essentially. So what these guys did is I was in the department we were doing this, so you'd put an IV cannula in and you'd put the probe cover on, and then after you took the probe cover off of the ultrasound machine, you would then put it in a little tamper-proof bag, and then these poor registrars of James's had to then basically fill them with water and see if there was any discernible leak. So did we perforate, or was the bag already pre-perforated, or we don't really know when the perforation happened because that's not something that this can tell us. And basically this is a surrogate marker for how leaky is your probe and how unclean or unsterile is your procedure that you're doing, it's an interesting question. And subsequent to this paper being published in the same journal, I think we covered it maybe last year, was Pete Snelling's paper looking at, they actually did swabs of probes that had covers and not covers, which is a microbiological equivalent of this, where they were sort of looking at, what bugs turned up when you actually run it over someone's arm. Do you remember that paper? It seemed to suggest that probe covers.
I feel like the way I wrote this up, I don't, because that's my big question, is whether these things do bloody anything at all for like of clinical importance. Like I don't know. I understand how dirty probe covers are, but there's always a good gap. Like my needle's here and my probe's here. Like, are bacteria like long jumping onto my needle? I'm not sure. But
anyway, so go look that one up. It's Peter Snelling is the lead author, and I'm pretty sure we covered it last year. If not, we can cover it in the future. So I'll tell you a bit of an analogy, Justin. You're a trapped audience. So I took my dogs. You've met my dogs, these big, stupid golden retrievers, and I took them for a walk in the park today. And as is tradition, they both did their business as we were walking around the park. And I have these sort of biodegradable, fancy poo bags, and I turn them inside out and put it over my hand and then scoop up the poo. And then I walk over and put it in the bin, and I walk around the park a few times, and then I go back home. And I'm quite happy to do that, but I'm not going to cook dinner with those hands. I'm going to go and wash them first. So it depends on what level of sterility you're after. And I've had a chat to James about this paper, and I think you and I agree, and James has said the same thing, is don't trust probe covers. We know that even the best probe cover, and in this paper it was 2.5% or something, had a leak in them. So if you're doing a procedure where it's really important that you have a sterile probe, clean the probe properly just before you do the procedure, which is not always easy in the emergency department, because often that's a rush job because you have to get that line in straight away. But I think that's probably the take-home point, is that probe covers will do some of the work, but they won't do it all. And if you're really worried about infection, so you're putting a line into someone's neck, for example, or a femoral outline or something, then you want to make sure you do it with a clean probe. So clean it yourself, because don't trust the guy that came before you, because he probably didn't do a great job of cleaning his probe. So most of us don't. Thoughts?
I don't know why I didn't make it into my write-up. It just didn't dawn on me. But there's one thing that this would have been so easy and would have made this paper dramatically better. We don't know whether these leaks are from you guys mishandling the probe covers or not. What I would love to do, you needed the control group of testing 10 new covers that were never used. Like, what is the leak rate of an unused cover? Because if they're just coming from the factory this way, it doesn't matter. I don't know that I care about a leak at the end of the procedure. Like, maybe it's from taking it off the probe like half of these came. So that maybe is the biggest problem here, is that we lacked a control. What's interesting, I don't think we mentioned it yet, is that this became sort of a natural experiment. Like, it started using, I can't remember whether you were using polyurethane first, and then
they were using the cheap polyethylene ones first, and we upgraded.
So it wasn't in the trial. The department just changed for financial reasons from one to the other. So you end up getting this natural comparison, and it looks like the polyethylene is a lot worse. I don't know my plastics well enough to know, but in terms of that, I'll throw in the one caution. In a natural experiment, that's really interesting, but you do have a group of people who are introduced to a brand new product. And if it was a tighter fit or a looser fit, you may have just been mishandling it. Like, you may have not had enough practice on putting it on off. So I can imagine a higher rate of tearing just because, we haven't used it this way before. We're used to rolling it on this way. We're used to being able to handle it in this way. So it's one of these studies. I generally think washout periods are a scam, but you almost sort of want to give people 3 or 4 months to learn how to use the new product and then see what the perforation rate is. That'd be my only comment about, like, taking this study and being like, no, nobody should ever use these probe covers because they're cheaper and they're crappy, which sort of this makes it look like is not necessarily the take home. I don't know you can definitively say that from this trial. But to me, the big thing is, you've already said, I don't trust the probe cover at all, or the probe at all. I spend all my time cleaning the probe before I use it, rather than worrying too much about exactly what happened with the cover.
And I think
we're going along. The thing that stood out to me as really interesting is, and I've noticed it before, working in Australia, working in New Zealand, working in Canada, is this almost all of these procedures are IVs. And it's funny. Like, since I've been back to New Zealand, I have put in 0. Not one IV. Not a single, never. Not one ultrasound guided. I put in one crash femoral line in a DKA patient who has been in the hospital 100 times, and people have tried ultrasound IVs like the last 6 months and nobody got one. So I just went straight to a central line. So maybe that one I should have tried the IV. Maybe if I was you, I could have got it. But in Canada, IVs are a nursing procedure, and they never come to me because the nurses just get the IV done. And as soon as I went to New Zealand, I was approached like 10 times a shift being like, I couldn't get the IV. And I wonder, like, as soon as you have a backup, as soon as you can make it a doctor's problem, or as soon as you have the ultrasound as a crutch, it seems like this like ramps out of control. But it's amazing to me that in Canada, nobody needs ultrasound guided IVs. Even like I'm working in a place where there's a lot of intravenous drug use, like they should be difficult. And I'm just like, 0 of my shifts do I need an ultrasound guided IV, but you guys are doing it just constantly. So just a small. It's not a critique. It's not whatever. It's just an interesting cultural difference between places.
It is weird. I'd be more than happy never to do another one. That is a strange thing. Like, most of ours are now done by the nurses or by at least the interns and the junior staff. So I only ever really get asked to put drips in when 3 other people have had to go in my big hospital. Whereas when I do anesthetics, I have to put all my own drips in. And like I say, I don't trust anyone, so I do it all myself. So that's, maybe we have trust issues. Maybe that's the real issue here. It's the psychology. And for those of listeners who haven't heard James, he was on our episode that we did when you were out here in Perth a couple of years ago, and he actually did a little beer coaster calculation on this, like how many high level disinfections would you need to do? So that's like putting the probe through the CSSD or the big machine, and he reckons it's about, you'd have to spend about $5 million on high level disinfections to save one catheter related infection. So just use a probe cover and then clean it if you're doing something. But it's the problem is that doctors don't listen, and they have dirty hands, and if we get the doctors to wash their hands, that would be a start, Justin, because I think our compliance rates with hand hygiene are the worst out of any profession in the hospital.
I don't know that we want to go there. Did you ever hear I think it might have been on MRAP, or Scott Warringard, it extended to like a 10-part series on how he doesn't think the evidence for hand washing is at all relevant. I don't know if you're I sort of agree, because it ties right into this, because I watch the probe, but like I don't touch patients with my hands, never. So the hand
Really?
washing becomes a lot less important because I put on gloves. Like I just like that. So I touch the patients with my hands, but I just put on gloves. Same with the probe cover. So like, yeah, if you were a patient, would you want this probe to touch you that has been Lord knows where, or would you want your doctor to wear gloves? Would you want the ultrasound machine to wear gloves? Like it makes sense. I'm not sure that how evidence based it is. Whether you would ever find a real, to me, probe cover versus no probe cover, and actually looking at like true infection rates, bacteremia, would be an interesting study. Nobody's ever going to do it because it's just too common sense to wrap the probe up, right?
And I think one of the problems with that catheter-related infection is that our infection control professionals that work with us seem to think that there's a zero, that if we do this all properly, there'll be zero. And that's just complete fanciful. Like we might halve the rate, but it's not going to go to zero. It's going to still be a problem. So we're never getting away from this. So it's just the nature of the beast. So, all right, let's move on to the next terrible paper, which is
terrible, but you kept sending it to me. I feel like you emailed it to me more than once. I love a bunch of people sent this one to me after I deleted it from my things. I'm not entirely sure.
It's an interesting paper because it's interesting in that if you read this and you had a bias towards I don't like CT scanning people, or I think that this or that is overrated, you could read this data however you want and just reinforce your biases. So I think it's important that we talk about it, so we say what this data actually says about patients in the emergency department. Okay. So this is a huge problem in emergency medicine, particularly where I work, because everyone's 90 years of age and falls over on a regular basis. So and one of the main problems in our emergency department is that the bottleneck in our emergency department is the CT scanner. And so if you can avoid CTing yet another old person that's slipped and fallen in the bathroom, that's, that you could get them out of the department a lot quicker and improve our flow a lot. But should we be doing that is the question. Should we be less aggressive with our scanning? So this paper is entitled Risk Factors for Traumatic Intracranial Hemorrhage in Older Adults Sustaining a Head Injury from Ground Level Falls. And this is a systematic review and meta-analysis of about 17 papers, and they had about 22,500 patients in it. It's a real hodgepodge of primary literature here. So we've got some prospective and some retrospective stuff from all different shops and different systems. So it's really hard to sort of analyze it. But of course, Justin, you've gone through and read all the individual papers yourself and critiqued each one and can tell us the answer.
It's a joke. It's a joke, but it's real. So if you look at evidence-based medicine websites, they will give you a checklist on what you're supposed to look at to critically appraise a systematic review. And it's true that there are ways to screw up a systematic review, but almost never that happens. The review uses good review methodology most of the time, but the entirety of a critical appraisal of the systematic review is, was this good data to start with or not? Which means every time I read a systematic review, I have to read all of the goddamn individual trials, which it's just why did the systematic review happen in the first place? Unless they actually, because once they do the meta-analysis, they think that math can stand on its own. They don't actually go in and read the bias. And I think these authors, unfortunately, they're Canadians and they're a good group of people, but they missed the boat in their analysis here big time, because I think they let the math stand in. Bottom line is, I threw out this paper instantly, just like I said earlier, and I threw it out instantly based on the abstract for one very important reason. They found that anticoagulants have no impact on your risk of traumatic intracranial hemorrhage.
Or possibly even made it less likely.
Yeah, so warfarin was zero risk, but apixaban, rivaroxaban actually make it less likely that you are going to bleed. There's two ways you can read that. Either you've just flipped the entire physiology of medicine upside down and this is the most incredible finding of all times, or the entire data set is needlessly, hopelessly biased. Like you just can't do well, as soon as you see that, you know that data is crap and you should just throw it out. And the authors should just say that. They should say, like, you get all the benefit for doing the meta-analysis still, but just say, this is bad data. Don't make any decisions on it. Instead, they actually have the quote. I think the quote is, do I have it here? Yeah. These results suggest that anticoagulants may not be associated with an increased risk of traumatic intracranial hemorrhage in this population. You really wrote that down on paper and went to publish that? Like, come on, guys. The bias to me is pretty obvious, although there's always going to be multiple confounders, but this isn't a group of studies where they just CT scanned every patient. Doctors are still selective about which patients they CT scan, and we send every patient on an anticoagulant to the CT scanner, but you don't send every aspirin patient, and you don't send everybody who's on nothing to the CT scanner. And so the bias is cooked. This is a study of patients who the doctor was worried enough to order the CT scan. And I realized that, if you trained after the year 2010, you're CT scanning 100%. So maybe that's what these authors were thinking. They think that you scan everyone. Maybe in their hospital you scan everyone, but you don't scan everybody. That's not how you do CT heads. And so it's biased. So to me, they present a bunch of numbers. There's a table that you can look at in the write-up that will go, and the top numbers that have big likelihood ratios. I believe that a clear depressed skull fracture is a risk factor for finding something on the CT scanner. Like, that makes sense. I believe that a focal neurologic sign is a finding, right?
Yeah.
But everything else in the middle, you can't do anything with it anyway because they have odds ratios of like 2. So who knows what they mean? But I think all of the numbers, if anticoagulant is so obviously biased, I think everything else here is also clearly going to be biased. And so basically, to me, these numbers should not be used because it's just telling you that the underlying data, it might all be from that one bias where it's just selection bias where physicians are already judging who to send. There might be other biases baked in because this is just not a clean data set. Either way, this is not data you should use to make decisions in any way, shape, or form. And I'm a little bit disappointed that they didn't get that into their conclusion. Like, that should be, to me, so obvious. How did the editors and the peer reviewers not make them make some kind of comment on how bad this data set is? I don't know.
Well, I can find other ways to blame Canada for this, actually, Justin. So, so I don't know how many times a week I hear that if the patient is over the age of 65, they automatically fail the Canadian CT head rule, so therefore they must have a scanner, which is not actually true, but it's every patient in this trial because they're all over 65 years of age by definition. So if Richie Hayes, one of my colleagues at Charlie's, if he's listening, he'll be laughing out loud because I think he has a lot of arguments with people about clinical decision rules for scanning old people's heads. But so I think that's basically what's going on here is that people have applied a rule, I'm guessing, and because they're old and they've got an extra tick or two, they've scanned everyone that's old and on blood thinners. So that was. I will pick you up, though. The authors of this paper, if you read the main body, not in the final discussion, they actually wrote that they acknowledge that there's an indication bias for why the CT scans were done, which is what you've just described. And then they completely ignore that and just come up with a conclusion which says, oral anticoagulants are fine, don't worry about it, which they actually do recognize that there's an indication bias creeping into this whole data set, and then they just ignore it, which is quite bizarre. So anyway,
these are very bright people. Like, I just don't know. It's like one of those ones, I think maybe too many cooks in the kitchen when you're writing a big paper and everybody's contributing. And like, I've been part of it once or twice before. And I think nobody's like responsible for the final draft, but it seems like a pretty big oversight to me. I will point out, not only you're right that the Canadian CT Ed rule does not say that you should do it to everybody, but it's one of the few decision rules that has an RCT. I think pretty sure we talked about it before.
We did, yeah.
Prove that it should not be used. If anybody is using that rule, you are hurting your patients. There's an RCT that it shows very definitively that you do worse care using the rule than you do without it. And so if you're doing it, you are a bad clinician. That is my fundamental rule. It is wrong. Somebody will that is going a little bit far, I realize. But yeah, it's you should not be using it. But it has clearly caused tremendous harm and tremendous misunderstanding. People are surprised, but like in my last shift, I sent a 98-year-old home with a head injury. But the key is no anticoagulants and no antiplatelets. So there's no way that I could have changed her management. She walked into the department and was talking to me. So like, there's no way that it's neurosurgery right now, and I'm not holding an aspirin. That would be the one that, like, I think you can be pretty liberal because like maybe even a clinical change is like I might just hold your aspirin for a week if there's a very small bleed. So I think you can be very liberal with a lot of patients. But like there was no way that her management was going to change at all. So like, why? And patients end up super happy about that. Like nobody wants to spend 6 hours in your department waiting for low value care. We do it to cover our asses, but the patients are very, very happy as long as bounce backs. We get really worked up about. Bounce backs are only make your patients angry if you never discussed the outcome with your patient. Yep. If you talked about it, like this case is going to be the family, but like you talk about, hey, there's this very small risk, but like safety-wise, there's no change. So all we're making here is a convenience decision. Is it more convenient for you to sit around 4 hours to get the CT scan today or have a 1% chance of needing to come back tomorrow and re-register? Like, which one of those sounds worse to you? Let them make their decision, and they're happy. They're so happy that you're trying to save them time. Like, that's just part of good medical care.
I do have that thought quite often in my department, where often the neurosurgeons, they want a CT and then they want another CT sort of 24 hours later, and we're just like, can we just send them home and they can come back and have the scan tomorrow, because they'll be in the queue that long anyway. So so probably the only useful numbers I think that are worth taking out of this paper is, I always love getting those baseline numbers out of the paper. So of these 22,500 patients, just under 7% of them had a traumatic brain injury, and only about 1 in 200 ended up needing a scan. I think that's useful numbers to take to your patients and say, look, in this age group, we can sort of say that the risk is roughly 1 in 200 that you'll need to have a brain injury that actually needs some sort of intervention done on it. And that's something you can discuss with patients in terms of numbers, like, because you can say to people, do you want to wait 24 hours in the department, or do you want to go home and take that risk? And I think particularly for those low risk patients that are otherwise pretty well, and particularly if they're on a DOAC where that's protective, you could probably just send them home. Sorry, I'm being facetious.
That is a massive overestimate, because that is in the group of patients where the doctor wants to CT.
Sure,
so when your gut is like, I'm going to send this patient for a CT scan, that's how low the risk is. I phrase it a different way. They found a lot of bleeds, but less than 10% actually had anything done about the bleeds, any urgent neurosurgery procedures. So I think that's the other important one, is like, we get so focused on making the diagnosis, but if only 10% of all the diagnoses you make actually have any change, you're probably over imaging. There's a lot of things that you didn't actually need to find that didn't affect the patient at all. And that's the number that really makes me comfortable being like, like, it's true. There's less overall matter. The bleed rate is definitely higher in an 87-year-old. But if somebody finds a 5 millimeter subdural tomorrow that was there, like, I think to me that is going to be a marker that I am a good doctor practicing good care. As long as I discussed it with my patients, nobody's going to be upset, because it's the secondary step of when did management change, and it's very, very rarely. And that's the important number to me.
Yep. Cool. All right. We'll move on to the next paper. This one, I think you just need to go and read for yourself. This is entitled Educational Strategies to Prepare Trainees for Clinical Uncertainty. It's in the New England Journal of Medicine, October 2025. And I really love this paper. And Justin, last week I was over in Melbourne examining for the College of Anaesthetists for the GP exams. And it was a fascinating thing to see people that were very junior doctors sitting these exams. I was just blown away by how much they knew. Like I would have definitely failed that exam if I had to sit it tomorrow. And I've been doing this for 20-something years. But these young people just knew everything. And it was just, they could just prattle off all these great answers. But the interesting thing is that if you looked at, if you gave people a scenario, so it was a heap of anesthetic scenarios, and there was always, sick patient, not so sick patient, tell me how you'd manage this, and da-da-da-da. And the really sick patients, they all managed super well. They always went, oh, yeah, we're going to do RSI, we're going to do this, this, and this. They all knew the answer perfectly. And the really easy patients, they all knew what to do as well. But it was those ones in the middle where there was like two easy, equal ways where you could have done something. And the really good candidates could describe, well, these two things are both about equal, and I could choose this or I could do that. But the ones that were not so good, that was the real discriminator, because it was those grey area patients where there's no right way to do something, where you just had to sort of suck it up and go, I'm just going to choose one option. The candidates that struggled in that area. So that was really interesting. And I think that I just read this paper on the plane on the way to Melbourne, and it just was ringing alarm bells in my head, and that it's something that we don't train our trainees for very well, as dealing with those grey areas. Like, they're all fantastic on the ends of the spectrum where Blind Freddy knows what to do, but it's the ones in the middle which is really tricky.
No, I'm glad to hear that you still have some good high quality oral exams like that, because the thing that jumps out to me from an educational standpoint is more and more our exams have shifted just to like the multiple choice. But and so like almost all of medical education seems to indicate that there is an answer. Even lecture, like I go to conferences and all these kind of things, and basically all the cases presented always seem to go to an answer, even when there's like some ambiguity. But I got invited to this grand rounds not too long ago. We were talking mostly about cognitive biases, but this case was insane. The guy managed a VFib arrest. And VFib arrests normally are MI, so like MI is on your mind. But then he gets to the hospital and finds out this guy's had a couple PEs in the past and maybe isn't so good with his anticoagulation, so sends him through the scanner. and there are multiple PEs everywhere, but all pretty small and no signs of right heart strain, but also a big aortic dissection. Not type A, just type B. Probably not because of the arrest, but it's there. This is real world. So like, are you still thinking down that line because there's no right heart strain? Should you treat the MI? Do you anticoagulate for all these PEs that are there when there's a big dissection? Yeah. Like, that is real world. That's what happens in the real world. That will never find its way onto the case. And so there's a reason this ends up on ground rounds, because you have a long conversation about it. But that is a really interesting case that I just don't see put into medical education. The one that I use all the time in medical education, one of my very first patients, chest pain upstairs. I diagnosed her with a STEMI later when she gets to the hospital, but she was walking down the stairs to call the 911, fainted, fell down the stairs, and now has an epidural hematoma. And there's this whole debate about, like, we need anticoagulation for the MI and where you go. Those are extreme, but these kind of decisions where, like, we know, you tap a joint and there's crystals everywhere, but there's also a really high white count. Well, we know that crystals are actually a risk factor for septic arthritis, but you already have sort of a diagnosis. Like, we need to be a lot better at discussing the ambiguity in medical education, and I don't think we do a fantastic job of it. We present cases as if there's a white count cutoff, or there's like there is an answer. So yeah, I thought this paper was interesting. I had just given a talk. I think we gave it in Perth before, a version of it, this embracing uncertainty talk, and a big part of that is fit with the paper above was I think a big driver of our CT head use and our decision rule use is because we're scared as hell of uncertainty. And so we like these objective seeming tools to go. And so obviously it fits into my soapbox, but yeah, to me, that's about all we can really say about it. Is if you're interested at all in what we've said, it's a good little essay in the New England Journal of Medicine, and it's worth having to read yourself.
Cool. There was another paper that came across my desk the other day, which was in the similar vein, and it was I think Ruben sent it to us. Did he? I think it was the CRP as the emotion. Yes, CRP as an emotional support tool for emergency doctors. It's like oh, well, I'm not sure what to do. I'll just look at the CRP and that will tell me. And it's sort of it's really interesting. And yeah, I think Simon Carley did a great job of sort of promoting the idea of probabilistic sort of thinking in the emergency department. But we do need to go that step further, because it's not just about diagnostics, it's about management and treatment and all that sort of stuff. And you've given those great talks on thresholds, and so people need to go back and have a look at that, because that's how things actually happen in the ED. And sometimes the right thing to do is just go and talk to the patient and go, I don't know, what do you want to do? And that's very difficult to learn if your training has taught you that there is a diagnosis and there's a treatment that follows that diagnosis, because that's tricky. Yeah. Cool.
Yeah, I think it just drives us really, really hard in a way that is this is a hard part of medicine for sure, but it becomes a lot easier when you realize that it's not you with a gap in your knowledge that isn't I don't know. There's just some fundamental parts of life that we don't know. And therefore it gives you a little bit of leeway. It gives you leeway to use that you've been trained for all this time, to use that judgment, and then like bring the patients in. You don't have to make the decision by yourself. Talk to your patients about it. Yep. It gives you leeway to do, if you're a little more on the conservative side, you can do it. I use this leeway to send a lot more patients home because I'd rather them get them out of my emergency department. And I think they appreciate that, but it's fine. I can't argue with you either way, but I think really embracing it will help with people's stress in emergency medicine. Because to me, the big stress is thinking you don't know and thinking it's because you're an idiot and you should have gone to it was that day you skipped school and medical school to go play golf or whatever that everything fell apart. But actually, no, it turns out that we're all in the same boat and everything's going to be okay.
But that requires role modeling from us old greybeards so that the young up and coming can see that. Yeah. All right, mate. So we're getting towards the end. Next paper, yet another editorial, which I think it would be really good if everyone go and had a read of, because it's not very long. And this is from your Canadian friends once again. This is Eddie Ling. Can emergency medicine be saved? In the Canadian Journal of Emergency Medicine a couple of months ago, 2025. And these same guys did the paper. What was it entitled last time? It was on a similar theme. It was are we doing too much or something like that in emergency medicine? It was it was sort of around
I can't remember the other one, but yeah, Paul Atkinson is the other author. And but yeah, both these guys, big thinkers. And I like this. This is a big overview, thought-provoking paper that we already referenced. I mean, obviously with the title like "Can Emergency Medicine Be Saved?" It brings me back. I believe it was the Weingart versus Simon Carley debate at SMAC. One of the big SMACs, maybe in Dublin, was basically this exact same question. Yep. And this sort of hits on the same points. And over the years, I've actually vacillated back and forth on where I feel about this topic, because there's a sense of pride of we are open to everybody. If your surgeon's sleeping in the middle of the night, I'll look after you. Whatever it is, like we take all comers and we look after all things. But the flip side is the more things you have to do, the less good you can be at any single one of them. And that's sort of the big point. But do we really have a core goal, a core mission? And they would say our core mission is to take that critically ill patient. They have a really nice quote in there that I'll butcher, but the critically ill patient and stabilize them. That is our core goal. Our core goal is not addictions care and social work and physiotherapy and everything else that happens to get dumped on us at all times. And so the question is, can we structure it's not structuring emergency medicine. This is why this is such a hard fix. Can we structure medicine in a way that allows emergency medicine to survive? That's the big thing, right? The surgeon needs to be available on a Saturday to manage post-op complications, or else it's always going to be us to manage every single post-op complication. The gynecologist needs to be available. I don't care if it's, a 3-week follow-up appointment, but it can't be where I am. We're getting 9 to 12 month follow-up appointment. Now all of a sudden I have to be a specialist in gynecology because that's just not appropriate. I can't, that's now my problem, right? Like this is the problem.
I just got to point out that if obstetricians are doing longer than 9-month follow-ups, they're missing a lot of billing. But anyway.
It's like the surgical guys who always book their post-operative follow-up appointment at 6 to 8 weeks, which is like beyond any complication. It's like basically you are like, I'm going to make sure that I see you when everything's dealt
back
with.
To normal.
No chance of there being anything wrong. Yeah, okay, that's good.
That's good. Yes, so interesting one, and this is a big conversation that's happening in Australia, and I'm sure all parts of the world at the moment is what are we trying to do with emergency medicine? And this debate's had pretty much daily on the flight deck where I work, and yes, we can do all these things, and we can train all our junior doctors to be amazing clinicians that can manage everything from toenail cuts to STEMIs, but we have to decide what we actually do want to do, and I think it's tricky, and it really depends on the geography and the system that you work in. But yes, that I do love that these guys are putting out there the realization that it's a finite basket, and you have to choose what you can and can't do. So we need to push back on some of that in emergency medicine, I think.
And it's so hard when you have a patient in front of you. Take a really stupid, benign example, but we debate all the time. Like, should we be doing anything about hypertension? And like when you have a patient in front of you, just saying, "Oh, see your family doctor," if that appointment's going to be 6 weeks out, like that, I think is technically the right answer. But like, why not get them started on a high blood pressure medication? It's so easy. They're your patient right now. You can look after them. But now to do that, I need to know all the latest literature on blood pressure management and all the potential side effects. And there you go. And it's just one small decision. You can do that times a million for absolutely everything. And I don't know, like I have colleagues who are like absolutely adamant that I need to be starting high blood pressure medications exactly for that, because it is true. It's a patient in front of me and I should be looking after them the best that I possibly can. But the flip side is, yeah, you can say that about literally everything. And it gets to the point where, I mean, it's interesting. We've taken on so many things. We now do ENT scopes all the time.
Mm-hmm.
GI, where I work, almost everywhere that I've worked has never been that thrilled to come into the hospital. And so, we take over more and more procedures. Why don't we just start doing scopes? Like I can push the foreign body down in the department. Maybe I should just start doing that as well. Like it's within my skill set. I can use the scope to look at a bunch of different things. Yeah. And so you can imagine that, like, you could basically just take over. Maybe I'll start doing that. And then like, oh, well, the surgeon doesn't want to come in tomorrow for your appy. Like, is it really that hard? Like a guy did it to himself in Antarctica. Like, maybe I should start doing that. Like, I don't know. When does it end? Right? Like when does this bloody slippery slope end? Is the question.
Yeah. That's a good example of that, as we recently acquired a probe in the emergency department for doing, toe-based resuscitation, and we can debate the evidence one way or the other. But then the next question is, so should we be doing toes on people that come in with AF just to check they don't have an atrial appendage clot before we cardiovert them? And it's just, sure, if you've got the skills, you can probably do it and have a look at it. How hard can it be if you're already sticking the toe down? You've done all that understanding of the anatomy and the training, but is that really our core business? And that's like 6 hours of the emergency department you'll never get back for that patient. So interesting, very interesting stuff. And yeah, I think great paper. So if you're in any sort of leadership position in emergency medicine, you go and have a read of this and take it back to your department, have a good long think about what it is that you do and don't do. And it will change from place to place, depending on what your population needs, essentially. I think that's what it really comes down to, is population demand and what we can actually, in reality, deliver.
Yeah, 100%. You can't say no if your local community doesn't have dermatology. You're going to be the dermatologist. It just is what it's going to be, and so I think you have to adjust. But yeah, the problem is not though. I think rural medicine has always understood this. The problem is I work in the middle of the biggest city in Canada, and it's not that these specialists don't exist. It's just that they say they can't see the patient for 4 or 5 months, and it was great. Like I'm very happy for a non-dying, non-critically ill patient to protect my surgeons. Like I'm not going to call you between 11 and 7. I'll hold that patient overnight. That's fine. But that we're protecting your sleep at the nighttime gradually morphed to 24 hours a day. Well, like now you guys know how to manage these infected wounds. Like, why don't you just do it without calling us? And then it like goes to the next step. It's like, why you like every little thing just adds to like you eventually you're expected to look after the patients 24 hours a day. Whereas it was just started with us. Like, I'm happy to protect your sleep, but like, they're still your patients, right? Like this is one of those things that like all of a sudden it now becomes my patient when it really is your patient in a center where you actually work and you're here. And so share the workload is like, I don't know, being collegial is really, really hard in this setting. Because the flip side is, yeah, they're busy, they're in the operating room, and I have the patient in front of me. And I do know I almost never call colleagues because I am a bad doctor too far the other way because I think I know what I'm doing and I just go ahead. But I do see colleagues who literally call specialists for like every single patient because it's like in their area of expertise. And I can see it from these specialists calling like, why are you calling? It's a neurosurgeon with a tiny bleed who gets 1,000 calls a day when we know, like, it's not going to be neurosurgical. Why are you calling me? It's like, well, I have to because of like legal things. So like it goes both ways. We need to find a way to protect everybody and do good medicine across the board. And I think we're failing across the board right now. The demands on all doctors are just too high.
Yep. Well, shall we move on to something that we're both clearly expert in, Justin?
Why? Well, what I'm expert in is finding very fun areas of PubMed. So you can ask how I found this paper and why I was in the rhinoceros section of PubMed for sure. But I don't know. Retirement job?
I've got to say, I spent much more time reading and going down the rabbit hole of this paper than I did of any of the other papers that you sent me. So
that'll be obvious to our listeners. If anybody made it through the full, we're past 90 minutes already talking about non-practice changing papers. And we're going to end with, I'll read the title.
Go for it.
The pulmonary and metabolic effects of suspension by the feet compared to lateral recumbency in immobilized black rhinoceroses, Diceros bicornis, maybe, captured by aerial darting. I don't even know the name of the journal of Wildlife
Diseases.
I don't know what DIS stands.
Diseases,
maybe.
Yeah.
There you go.
Yeah.
Back from 2021, so I'm a little bit behind on this. I apologize for it took me so long to find this paper. I don't know. Do you actually have comments on this paper? Did I just put it in for this one picture?
I learned so much. Actually, with our anesthetics training, every year we get one of the vets from the zoo to come along and give a talk on like veterinary anesthesia, and it is so fascinating the stuff they do in veterinary anesthesia and the skills they have. And so they dart these rhinoceroses usually so they can move them out of a poacher's way, so they can move them to a safer location. And black rhinoceroses are like the most endangered rhinoceroses in the world. There's like a handful left in most places. And so can you imagine anesthetizing a black rhinoceros, which is like invaluable. Every single animal out there is like invaluable to the species survival. And you're shooting them with a combination of, it's basically a super potent opiate, which is etmorphine, and then basically a rhinoceros equivalent of like dexmedetomidine and some midazolam or something at the same time. So you're shooting 3 heavily sedating medicines into this like invaluable animal, and then you're sort of running up and hoping it's asleep so you can start supporting its ventilation in the correct position. And I just love the fact that the vets are doing these like nuanced studies about, should we hang them by their feet or roll them on their left side or the right side? It's just awesome. And it was really interesting to go through. I've got a couple of nerdy comments, if I can. Yeah. The species name of the black rhinoceros, Diceros bicornis, I'm pretty sure that's just saying the same thing twice, once in Greek and once in Latin, because Diceros means 2 horns and bicornis means 2 horns. Like it's It's just a weird name. I just wanted to put that out there for any Greek scholars. Yeah, it's quite bizarre. Anyway, so those of you that don't know, I can't believe I'm saying that, but you made a comment in your write up that the oxygen saturations were like super low, and it seemed like a bit iffy. Like if you were doing an anesthetic and the oxygen sats were in the 70s, you'd be like, "This isn't good. I need to intervene and do something."
I was a little bit worried. We're trying to save these rhinos forever, but I think basically we need to build a giant rhinoceros nursing home for all the hypoxic brain. Like, you darted these rhinos and we're satting 60%. Like, yeah, maybe they didn't get a poacher, but like, are they really going to be able to mate and survive in the wild, wandering around? I don't know.
Well, it turns out that this is... No, this is a we talked a little while back about the how different SATS probe didn't pick up SATS and the different skin colors. So that great paper, and it turns out that the saturation monitors that use are human saturation probes that are calibrated for humans, and black rhinos evolved in high altitudes, so they're actually got a really left shifted oxygen hemoglobin dissociation curve. So this is actually fine for them. So they're like walking around with SATs, which we're measuring at sort of 80 or something, but in reality it's like 15 points higher, so it's fine. So
that makes me feel so much better about this paper, because I honestly like looking at this and like I think somebody's missed the entire point if you're doing species conservation here. So I'm very, very glad. I didn't have the time to go down the rabbit hole. I'm glad that you are that nerd, my friend.
But I do have a question for you, Justin. Let's just say that you're the vet in the field. You've just started this rhinoceros, and you have to run up and put the SATS probe on. Where do you put a SATS probe on a rhinoceros to get a reliable reading? Because their skin's like an inch thick.
Yeah, so you're going to tell me it has to be on the penis or something like that, right? I guess the earlobe is like the
slightly more
thing, I hope.
It's a lot of animals have, especially herbivores that live in dusty environments and have to have their eyes open all the time. They have a third eyelid that comes across that way, and sort of it's transparent and wipes across their eye. It's called a nictitating membrane. So they put it on the third eyelid, which is, I think that's just wild. I'm going to try this at work next week. So that was really cool. That's all I had for you. That was about it, really. But the outcome of the paper,
medicine is fascinating. There may be more. I might already have a paper on raccoon evolution slotted for our next talk through. I don't know. There's just something about it. I think maybe one of the very first SMAC talks I ever went to was the great John Hines, and he had images of hippopotamus CPR, I think, and somebody's just jumping up and down on the chest.
I do recall it. Yeah.
Brilliant, wonderful talk. And it just every time I see one of these big mammals getting some kind of medical procedure, it just leaves me in awe. So I think that's what led me into this paper. Clearly a ridiculous way to end the month, but I think there was still some good papers overall that we've spent an hour and a half talking about in there, even if they're all have their flaws. Good conversation, I think.
I think the my final point for you is that if you ever think that you've got a tough job, Justin, the veterinary specialists that look after these big mammals like rhinos and elephants and that sort of stuff, they use these amazingly potent opiates to take them down. And their protocol is they actually stand there with like the dart gun with the opiate in it, and apparently stabbing yourself just with the needle tip is enough to put you into a coma, or stop you breathing within like 2 beats. So the protocol is they have a friend standing next to them with like 2 big syringes of Narcan ready to go, just in case. So you're not allowed to go out and shoot something unless there's a guy standing next to you with a big syringe of Narcan, like right there. So there's immediate harm reduction right in front of you. So
I don't have to be the actual guy in charge. I can just be the Narcan guy and get this is a retirement job. I get to watch the darting, but I don't have to be the guy who runs up and goes right next to the maybe sedated rhinoceros. This sounds like good. I like it.
You can just watch the guy get gored to death. It'd be much more fun.
No, I'm fine with that now.
Then you can become a human doctor again. All right, mate. Well, it's been a fascinating conversation, and I think that's a very fitting end to our series for 2025, and lovely Christmas sort of flavour to it, BMJ style. Thank you for sending that through to me, and I've learned a lot about rhinos, so I probably don't need to know, but hey.
Yeah. Enjoyed the conversation as always. Enjoy your time away on a wonderful trip, and hopefully talk to you soon in the new year.
See you around.